Dr. O'Neill, in 2003, the US government launched PEPFAR, the President's Emergency Plan for AIDS Relief, which is one of the largest commitments to date of any single nation to address a single disease. PEPFAR, as we know, has saved millions of lives across Africa and globally. And I'd like to ask, what were some of the strategic discussions that occurred around palliative care priorities in the early days prior to the rollout of PEPFAR?
Good question. So, PEPFAR was really came out of President George Bush's desire to do something. I don't think there's any other. I got to know him pretty well over the time that I worked in his White House, and I think he sincerely wanted to do something about the exploding epidemic, particularly in Africa and the Caribbean. I think probably if they said, well, why did he do that? I think it's probably his daughter Barbara was the one who pushed him harder than anybody else, and she's an unsung hero in this. I was asked to design the program, put it together, do the political work to get it through Congress and all of that stuff. And, I'd always been a strong advocate for palliative care in HIV because most of the time in my career and as HIV doctor, it was palliative care. There was no cure or even treatment, which is the case then and still somewhat, largely now in the continent where you work. So, I think that the key thing is that this program was always intended to be increasingly run locally. The large amounts of funding go out to countries, ministries of health, in that collaboration between the local representatives of the U.S. government, be it USAID or CDC, and the PEPFAR offices in each country with the ministries of health in those countries is really how the ultimate plans about how the money gets spent. We prioritize palliative care early on in the epidemic because it was in the original legislation. I haven't seen the reauthorized legislation, so I doubt very much that it's still in there. But all of the kind of, but because the words were in there initially, people were like, well, what is palliative care? It got people interested in it. I happen to see it as a critical part of the continuum of care that people with HIV need. But the plea that I always had from the very beginning to my colleagues in Africa and the Caribbean and Asia and other places in palliative care was to be thinking at the very beginning how you can make it clear to your own governments the importance of palliative care in this epidemic, because ultimately these decisions are going to be made by local governments, not by the US, which is, when you think about it, the way it should be. And that means, thinking through the arguments that need to be made, finding the data that you need to find in order to back that up. And I had this conversations many times with folks about really trying to integrate as much as possible palliative care into the larger healthcare system in a country, rather than operating it sometimes as we do in the US and in the UK as a almost like hospices are kind of a standalone operation that just doesn't work in countries where you have a very strong Ministry of Health that's running a very large and overstretched system that the ministry itself needs to really understand how palliative care fits into their priorities. And I think I think it was a wonderful time initially when PEPFAR was launched. I think it was great that there was somebody in the White House that was an advocate for palliative care. But those days are gone. And so it's really, and I don't think they're going to come back. So I'll stop there.
Excellent, thank you. So just to summarize, it sounds like what made PEPFAR really impactful was that one of its aims, its many aims, was to encourage ministries of health to fit palliative care and other AIDS interventions into local priorities.
Well, we said that palliative care was a priority for PEPFAR initially. Mm-hmm. That was in the legislation. And when it's in the legislation, then the US government had a bit of a, a stick to say, we have to do this, even though I don't think anybody had the same comprehensive understanding of palliative care that all of us do, because the words were in there. The funding, was able to fund it. It attracted funding, but that was really, to be blunt about it, it was because I was there as a palliative care doc and was pushing people to do it. But you can't just have one advocate, no matter how powerful that person is. And that's why the whole time I was doing it, my mantra was always, anybody that worked with me back there in the time, on the continent, knew I was constantly saying, you've got to figure out how to integrate this into the overall HIV strategy for your country, because ultimately it's going to be Africans making the decisions about what happens with the money. And so the degree, and that's really been the challenge, I think, for APCA, is to to develop the arguments, create the data, and to it's got to come from the African context that this is important.
Mm-hmm. Absolutely. Dr. Purkis, so the Diana Fund launched its palliative care initiative quite harmoniously just prior to the launch of PEPFAR in 1998. And this was quite historic, just to paint a picture. This was prior to palliative care indicators being formed. It was even prior to the WHO definition of palliative care. So as the CEO of the Diana Fund at the time, which metrics were most important to you to measure impact?
Well, I think firstly, it was the numbers of people who received palliative care and whose suffering was thereby reduced in relation to the amount of money that it costs. Because we were convinced that one of the tremendous benefits of palliative care is that it doesn't need to be very expensive intervention, and it has a disproportionate effect on large numbers of people where it's available in a form that is suitable to the circumstances of that particular country. So that would be the first metric. And then a different sort of metric, which is really the sort that Joe was referring to just now, was the degree of recognition and priority for palliative care within the official strategies and plans of health ministries, and medical services and so on, and health services at different levels, because we were not wanting to end up with simply a series of projects relying on external grant funding, which might then one by one fizzle out. Mm-hmm. The objective was to try to assert and promote the importance of palliative care as an integral part of the perceived responsibilities and systems in each country. So that was the other particular sort of metric.
So I think we're saying that pretty much the same. I mean, that makes a lot of sense.
Yeah, I just wanted to comment, if I may, on the original motivation for launching the program. I mean, this was, of course, because Diana, Princess of Wales, had shone a light on many different kinds of long-term conditions and sufferings which were associated with some sort of stigma. I mean, you'll remember that she made a very famous intervention in the area of leprosy. She was a very early and prominent supporter of people with HIV/AIDS and all sorts of HIV/AIDS initiatives. And she was also one that visited hospices and shone a light on people with long-term chronic conditions who were dying. And so when we considered, well, how can we make a difference in the world in a way that continues her particular work and inspiration? Palliative care in Africa, where it was particularly patchy, fitted that desire. And I still think, however difficult it is still highly relevant, because it's very difficult to attract attention to people who are suffering in private. It's always easier to get resources for curing people, but there's still something about the kinds of issues that Diana, Princess of Wales, brought to light about being alongside people so that they have a better life and a better kind of death. And it's one of the most important ways of alleviating unnecessary suffering. And that still has to be a very prominent part of the argument, I think.
Yeah, I think in both the cases we've talked about, the initial impulse towards compassionate response to human suffering was, very, very relevant and very operative at the time. I think it's still there, but the locus of decision making has really shifted. I mean, the Diana Fund is last time I saw you was at the Kensington Palace when it was closed out. But in terms of PEPFAR, as far as I know, and again, I'm not involved with PEPFAR any longer, but the locus of decision making is really, and I don't think there's anybody on this call who would argue with this, but the locus of decision making is really shifted to local governments, not decisions made in Washington, D.C. or Atlanta. So the country operating plans that are developed in country in consultation with, in the U.S. government, in consultation with ministries of health and NGOs in Kampala and in Nairobi and Arusha or wherever these are developed, that's really the key place where the decision has to be made. The funding decisions are being made now, and I think that's the right way to do things. So then the real question is, how does palliative care, become part of that discussion? And that is really a local process.
Mm-hmm. So I would like to ask you both, why, in your personal view, have donors shifted away from palliative care funding? Donors that are very compassionate in their response to global health issues.
Yes, that's a very important question, and I can only offer a very imperfect point as to why that has happened. I think that partly it's an optical illusion in that there were a relatively small number of quite big funders who, for one reason or other, in the case of the Diana Fund, they don't exist anymore. And so that has left a different sort of landscape just because they're not there. But I think one of the difficulties, I'm going to speak fairly plainly here, is that it's particularly associated, palliative care, with older people. And unfortunately, older people very often get the bum end of policy priorities. It's partly mitigated in some countries where there are enough of them and they still vote, so that on certain kinds of issues, they can still have quite a hefty influence. But by and large, in many different dimensions of policy making, older people struggle to get a voice. And so I think that it's quite important to form alliances with the relatively small numbers of organizations that work on development, that work specifically on
Are you still there?
people, like the Help Age network, for example. Sorry? I'm sorry, I thought I heard a voice.
No, we're having some.
That's fine. So I think we need allies amongst the Help Age network to assert the rights and dignity of older people and find common ground there to help to try to shift this perception. I think the second difficulty is that people that are suffering privately don't have as much impact as people who are out there, making a noise. And even in our own UK context, it's far more difficult to get any interest in and money for social care for people with long-term conditions, sort of people who are living at home with dementia, for example, than it is to get money for the National Health Service, hospitals, acute care, and curing people, and all the rest of it. It's less glamorous, and it's a lot of it is out of sight. People die, and I think we have to find ways of bringing home to people what the reality is of dying without palliative care.
Yeah,
and get them to understand that this is going to be them one day. And that it's not something that should just be sort of kept out of sight and under lower priorities. So those are a couple of quite big underlying issues as to why it's always going to be difficult to get proper priority for long-term conditions suffered in private.
I think those are really good points. And of course, for the HIV epidemic in Africa, the dying in private part is operative. The age part probably isn't, as because it's mostly young people that are sexually active and contracting the disease. But I just come back to, I think those are underlying elements, but how those play out and how policymakers are educated, that education has to happen in country. There's I mean, not to be too blunt about it, but you're talking to two guys that were involved I'll be 70 on my next birthday, so I qualify as being old.
I can do better than that, Joe, because I'm 73.
Okay, so I'm a relatively youngster, but the point is that the people that really can answer these questions for you, they have to be the people in, that are in, like for PEPFAR and I don't know about other international funders, but I can say, and PEPFAR has been the major funder of palliative care all these years. It's the people in your country that are making these decisions. And I can't really tell, how do policy decision makers make decisions? Some of it's political influence, some of it's who they know, but a lot of it is data. I would ask everybody there, at the meeting, how do you defend palliative care? If you're a health minister with a system that's being, that's straining straining to just cover the most basic things, how do you make an argument for palliative care in that system? And in that argument based upon what the priorities are for that health ministry and for those funders. And I don't see, I don't think that it's people don't care about this issue anymore, but maybe their answer is we need to train primary care people more in palliative care skills. Maybe we need our hospital systems to be more flexible, that maybe palliative care doesn't stay as a standalone service with standalone institutions, but becomes more integrated into a whole system. If there's one thing that Africans do is to be creative and flexible and find new ways to get to go. But I don't think that I think the days of having and I don't think any of us want this, but the days of having London or Washington, D.C. dictate to Africa how money is spent are rightly over. And those decisions are now being made locally. And if your members are not, this is grunt work, but I mean, it's down there, like who's on those committees, who are the organizations that are talking to the Ministry of Health, who are the organizations that are talking to, the USAID and in CDC and countries. That's where the real rubber meets the road to get work. How a global organization like APCA does that. I mean, in my mind, that's a role of a large organization, is to help local people develop those arguments, collect the data. And that's what, if I, at your conference, I mean, I think that should be a major focus of, what are effective arguments? Who's been successful? If there's have to be some people have been successful with their governments, how were they successful? What did they do? How did they go about doing it? Pairing up successful organizations with ones that aren't so successful. I mean, those are the kind of things, but the bottom line that everybody needs to know is that the action is no longer in Washington or London. The action is going to be in your own countries.
And if I may, I'd just like to add that was actually the thinking behind the Diana Fund. There may be others who claim paternity or maternity, but I think we were the sort of one of the original founders and funders of APCA, and
yes.
That was very much the thinking behind that the engine for trying to bring about this difficult long-term change in different parts of Africa must be Africa and must be led by Africans. And it's actually great that you're here still working away on that task.
I like those insightful comments, and we will actually task our ministers of health who are coming from across Africa to pitch this and ensure that when countries are undertaking COP plans, palliative care does feature, and it receives the due consideration it deserves.
And I think, and that's good. And I think that real thought should be given into how do you help them pitch this? What data do you give them? What information what stories can you tell them? I mean, maybe it's telling a particular story, but people need tools to go to, because there's a lot more need out there than there is money. So you're competing with a lot of other a lot of other well-motivated interests. And so how I mean, to me, the role of an organization like APCA one of their roles would be to develop materials and data and ideas that then can be used for that kind of local interaction.
Thank you, Joe. That is most appreciated. And good enough, we still have IHPC, which is working so hard to train advocates in Africa and supporting them with materials, policy briefs, and short statements.
Yes. To
really influence and participate in key meetings where these big decisions are being made. Yeah. So I think we need to strengthen. You guys do a great
job. I didn't mean to imply anything that you weren't doing it, but that's what I said was meant to say, that you're on the right track with what you're doing.
Yeah, I actually didn't appreciate that much. And I now want to give it the emphasis it deserves, since it's the catalyst for change. So Andrew, since your tenure working in high-level donor capacities, you've worked with THET, the Tropical Health Education Trust, and Action Aid. Why, in your view, have donor priorities shifted away from palliative care as a global health priority.
I'm adding to some of the fundamental points that Joe has been making about this and that you've been endorsing.
Yeah.
I think that there's a question as to how far the best tactic is to try to pursue this through health discussions, discussions within the world of health. Obviously, that's always going to be a very important part of it. But insofar as some of the decisions are political and influenced by politics, I think there is a sort of wider question about alliances that can be formed to try to promote greater salience to these issues. Now, again, this is something that is not for me to pontificate about from London. So I'm only sort of giving some for instances. I mentioned earlier that in some contexts, organizations that are working with older people, the Help Age Network, could be good allies because their clients are particularly likely to be facing long-term conditions and the approach of death. There's also human rights organizations, because ultimately this can be seen very much as an issue of human rights and dignity for people who should be receiving elementary palliative care and who are deprived of that, and as a result of that are losing a lot of their dignity as a human being. So I think there's quite important alliances to be considered with human rights and with different kinds of churches and other faith organizations where appropriate, because this ought to be one might consider something that's fundamentally relevant about organizations that stand for rights and for a particular kind of emphasis on the quality of life. So I think the question of alliances beyond the world of health are also important, as well as the points that have already been made very well by Joe about trying to muster the right kinds of arguments and data and stories and so forth within the world of health. Not an easy task, but really, really important one.
That is a very strong point, and one that I recall Dr. Faith Mwangi Powell made 2 conferences ago around palliative care organizations shifting away from siloed interventions and programming, and the power, the value in not just collaboration, but alliances. Dr. O'Neill, could you comment on that? How should palliative care reposition itself amidst current global health threats? How are alliances, in your view, to be made organic, sort of not paper alliances, but sort of functional alliances?
Well, the best place that alliances can be made is at the patient's bedside. So if you can have the, doctors, nurses, healthcare workers that are at the bedside of people, whether it be COVID or HIV or tuberculosis or whatever the disease is, to show the added value of palliative care, that's a universal thing that can always help, because it's a grassroots approach. I think the further you get away from that, the more that palliative care is let me read you Cicely Saunders' definition, and this is what we're doing. Well, we all agree with it. If it can't be made practically understandable to the people on the front lines as to how it contributes to health in ways that people understand and can feel, and because when they can understand it and feel it, then they can advocate for it. But I think if I think that it's the integration into where are the points? If you look at somebody with COVID in Uganda, for example, and somebody that's very sick with it, where are the points in that patient's experience that palliative care would intervene in a way that's perceived of as augmenting what's already been done? That kind of argument is a very different argument than one that's kind of comes from the top down, saying everybody has a right to palliative care, and a human, it's like you're in situations where there's not nearly enough resources to go around to all the healthcare needs that are out there. And so some things are, blindingly obvious that, medicine and nurses and, you don't have to do a lot of explaining why ARVs are necessary for people who have HIV. You have to do a bit more to explain why palliative care is necessary. So that's where you need really creative, you need good arguments, as Eve was talking about in developing, but I think you also need that advocacy for what you do at the bedside from people that are delivering the care. What in a meeting of what people that are at the bedside of people with COVID, what's the nurses that are taking care of COVID patients or tuberculosis patients, what are their priorities, and what are their needs, and how does palliative care mold itself to support them and their work? Because what you need is a broader advocacy that comes from the grassroots, because that's what people in these, we're talking about the ministries of health and local decision making. That's who they hear are their people on the front lines and the front grounds, and patients. And what do patients or families of patients that have received palliative care, what do they say? Why does I think it might be very compelling to have a video of family members who have received palliative care services, be it HIV or COVID or TB or trauma or whatever it is, to say this is why it was important. This is what I think it has to be. I think one argument has to be based on a very human, clinical level, and I think then the other argument needs to be based on a systems level. What do you add to the system? How do you save system money? How do you make resources go further? How do you increase satisfaction amongst people and families? I mean, Ann Berger, some of you know her, some of you don't, but I mean, she started the palliative care program here at NIH, and it was based on just like helping people understand how we help the overall mission of NIH, which is a research mission. And the arguments are good arguments, and that's why we have a program. But again, it's the same thing. It's the more it's kind of an esoteric, this is the right thing to do, it's compassionate, it's those arguments aren't going to hold nearly as much water as this helps us deliver better healthcare, more efficient healthcare, cheaper healthcare, greater patient satisfaction. That's what's going to win the day. I wish that arguments based upon other things would hold in this world, but they just don't seem to, do they?
Yeah, I agree very much with the thought that if we use language of sort of professional palliative care, it's quite easy to lose people who don't have a very clear idea or a sort of emotional feeling about what that actually is. So I think that that and other kinds of sort of abstract language by themselves will be ineffective. And so I completely agree with Joe about the importance of grounding it in the real experience of individuals and families. And then it becomes clear why it matters. And then you can form alliances. Yes. If you convey that, then you can form alliances with other organizations that will call themselves human rights organizations.
And that have similar motivation. Yeah.
So these are not opposites, but in a way, the precondition for successful argument within and outside the health area is grounding it in the actual reality of what the contribution is and why it matters and why it actually is transformative for people who are suffering. And so I quite agree. I don't think any of us is advocating some sort of top-down or abstract argument. I think it all needs to be grounded there. And I still think that however difficult it is, in the long run, it's so important to so many people when it is understood that there is tremendous potential for further development.
Yeah.
Absolutely.
And I think that can be told in many ways, including stories, including personal experiences of people. I don't think it has. So I think those things are important, as well as data and impact of. Here we can show that by providing palliative care, people have much greater satisfaction with their health care, that we spend a lot less money on futile futile end of life care that's very expensive and doesn't do any good. But those are the kind of arguments that have held water here, and I think that there's some thought can be put into that. Is what are the analogous kinds of arguments that make sense within the health systems that exist there? That's important. And then tying I think the emotional drive for this can come from individual stories, but the advocacy, if the advocacy is only coming from the palliative care world, it's not going to be nearly as powerful if the advocacy is coming from a larger health systems world where people see, gee, this really helps me, palliative care really helps me do my job. That's what it's true here at NIH, and it's true in rural Uganda. How does this, either as a family member or as a doctor or a nurse, a healthcare worker, how does the existence of palliative care improve the care that patients get and improve the lives of the people who are struggling to help them?
Absolutely. So grounding advocacy in patient story, anecdotes, data for efficacy and low cost impacts. Those are all driving forces, but let's be honest, that requires funding too, to fund those advocates and communicators and health messaging campaigns. So if you had, just in closing, one word of recommendation for African advocates listening to this, and they have the drive, they have the contextual understanding, but they lack the funding to continue the work that the Diana Fund and PEPFAR initiated. What would be your takeaway message to them?
I think it's just repeating what I've said. Funding is important, but the advocacy doesn't require funding. It requires people spending their time convincing. If you've got all the passion for palliative care in your hearts and all your people that are going to be at this meeting, that needs to be transmitted to outside that community. What's the strategy for getting that story away from the outside of the meeting to get more people lining up in support of you?
Yeah, and I would simply add, don't get despondent. APCA is a really good engine and supporter and promoter of ideas about this within Africa, and the human and health importance of this is absolutely without doubt. And if you all persevere and tell the stories as they are and form the right alliances, there will be progress, because it is so important. So I'm so pleased that you're on the case and will stay on the case.
Thank you very much. Eve, did you have any concluding thoughts?
I think I've received the concluding or parting thoughts, and they are important and very strategic messages.
With that, we'll conclude the session, the recording portion of it, and I'd like to again extend gratitude to this panel, and also to all the many donors that have funded palliative care in Africa over the years. Thank you.
Okay, thank you very much.